So that there is no confusion that I wrote this and you all think that I'm bright. This is taken directly from the blog of the Bill and Melinda Gates Foundation, who have dubbed my friend the impatient optimist. Ellen Ogden is the worldwide polio eradication coordinator for the U.S. Agency for International Development, also known as USAID. Ellen is the worldwide, I already said that, and a senior technical advisor for health and child survival. She's responsible for the agency's $32 million annual polio eradication program and related immunization and disease control efforts in over 25 countries in Africa, South Asia, and the Near East. As a technical advisor and project manager for grants to WHO, UNICEF, and NGOs working in polio eradication and child health, Ms. Ogden is responsible for a 15-year budget of $750 million. Through this portfolio, Ms. Ogden fosters close linkages between organizations working on polio and broader child health problems, recognizing the need for equity and access to health services for all children. It goes on down. She's a graduate of Tulane University and the Tulane School of Public Health and Tropical Medicine. Ellen has over 25 years of international public health experience in the areas of child survival, disease prevention and control, health communication, and health and human rights. She served as a Peace Corps volunteer in Papua New Guinea and as a Johns Hopkins University Health and Child Survival Fellow with USAID's Latin American Bureau. In 2008, Ellen received a rare USAID Award for Heroism for her efforts to negotiate days of tranquility in several conflict countries in Africa and Asia. She's also the recipient of the Rotary International's prestigious Paul Harris Fellows Award for humanitarian service. Ms. Ogden was USAID's featured speaker at the White House ceremony commemorating USAID's 50th anniversary. And thanks to this incredible woman, Rotarians and the Bill and Melinda Gates Foundation were this close. Please welcome my friend Ellen Ogden.
Well, it's a pleasure to be here. We've been working for a while. My travel schedule has made it really challenging to get out here. I live in Silver Spring, Maryland, so I am more than welcome to come out and speak to Rotarians at any time. So spread the word. I just have to be in the country. Also, to update you, the $32 million that was in that announcement has increased a lot due to Rotary's lobbying and engagement with Congress. So our annual budget now is $59 million a year. And that's a lot due to your efforts. So thank you very much. I promise to use the money well. So I always like to start with these slides. The kids on the right that have braces, those are paralyzed kids. And Rotary, more than anybody, understands the importance of preventing polio. But I like to start this way because I talk a lot about cases and there's dots on a map. And I think it's always just useful to remember that every dot is an actual case, a paralyzed child. And that the only way to stop polio is through vaccination, which is what's happening to the little girl up there. You know a lot of this background. It's a disease of childhood. It's caused by a virus. It's spread through fecal-oral transmission. It's been eradicated from much of the world. And now we only have 2 countries where polio has never been stopped, Afghanistan and Pakistan. And this year, the total number of cases is only 19, 13 from Pakistan and 6 in Afghanistan. And that's absolutely incredible given the conflict and the difficult situations, the internally displaced people. It's just extraordinary what's happened in the last few years. Africa, including Nigeria, has been polio-free for 24 months, another historic landmark. And as you know, we need to go a minimum of 3 years between the last case and when countries and regions are eligible for certification. And that means we're pretty sure there's nothing there, nothing hanging out, no silent infections going on. It's important to remember that for every paralytic case of polio, there's 200 silent infections. So just because a kid has polio, it's the tip of the iceberg. So we really try our best to immunize all kids under age 5 in large geographic areas so that we can get the underlying transmission. that may not be detectable. There's no cure. There's only prevention through vaccination. And it takes many rounds of vaccine. As I'm sure you've heard here in the US, where people are well nourished, we don't have a lot of other diseases, we have pretty good hygiene and sanitation. 3 to 4 doses was sufficient as a child to interrupt transmission and keep you fully protected. That's not true in most of the world, where water and sanitation are very bad. Kids are sick from all kinds of different things. So it can take up to 20 or 30 doses of polio vaccine to be as protected as a US child would under our conditions. 1988, just some landmarks for you. The World Health Organization resolved to eradicate polio by 2000. So I have to congratulate you on your patience, because those goalposts have clearly been moved a couple of times and the budget is increased substantially. But we are getting a handle on how you launch such a global effort and what it takes to reach the doorstep of every child in the developing world. The program's spearheaded by WHO, UNICEF, Rotary International, you're well aware, CDC, and the Bill and Melinda Gates Foundation. And now the revised goal is to interrupt transmission in Afghanistan and Pakistan in 2016 and have global certification by 2019. We're hoping that's on track. These 19 cases came in the low season, so we're hoping that we don't get anything going into the high season. But people are working very, very hard to make that happen. 4 out of 6 regions are polio-free. More than 80% of the world's children are living in certified polio-free areas. And as I said earlier, no documented cases in Africa in the last 24 months. This is something I think you're all familiar with. When we started in 1988, there were 125 countries with polio all over the world. And it was all 3 types of polio. Very cleverly named 1, 2, and 3. And so they were all circulating at the time. By 2014, we were down to only 3 countries and just a few cases. So truly remarkable progress in about 20 years. The last wild type 2 was in Aligarh, India in 1999. And the last wild type 3 was last seen in Afghanistan in 2013. By 2016, all of Africa had been cleared out of wild virus to our knowledge. We're still searching for that silent circulation, but as far as we can tell, there's been nothing in 2 years. And Afghanistan and Pakistan are the only 2 remaining countries. And if you say then, there's just those 19 cases. I'm not sure if you can see this too well. This is a picture of what's happened in the last 6 months. But the dots, I'll come this way. The dots in Afghanistan and Pakistan show the virus. It's on the western border of Pakistan, eastern border of Afghanistan. So that's a really troubled spot. A lot of conflict, a lot of population movement. The little dots in southern Afghanistan are in Helmand and Kandahar, where the greatest fighting is. The other dots in Pakistan are in northern Sindh, where that particular area does not affiliate with the national government, so they're kind of separatists in a way. So they don't want to have very much to do with the national polio program. And then in Karachi, which is a major city. And these are also linked to transmission routes that I'll show you later, where population movements and traditional trade and economic routes have people moving across borders. So there was actually an official ceremony to declare type 2 eradicated, and the certification commission came up with this little tableau to demonstrate how proud they were that one of the 3 viruses is gone entirely. But why is it so hard? What makes it so difficult? You think people would be running for the vaccine. Smallpox, everybody came and ran for it. Even in the 50s and 60s here, Sabin and Salk vaccines, people were afraid of of this virus. And the minute something was announced, it was headlines and people came rushing. Unfortunately, when you're living in a remote village outside of news and there's pressing needs on food, Maslow's hierarchy of needs, you need food and shelter and basic things that they don't have. This is not at the top of the priority list. So some children are missed all the time. They're either missed because they refuse or the teams don't go to find them. And you have children that are living in very isolated and remote areas. I remember going to Egypt once to monitor the polio campaigns. Have any of you monitored a polio campaign by any chance? Have you had? It's an amazing experience because you find kids living where you don't ever expect them. So I was in Egypt and we're going up and down the road, and most of the communities are built along the Nile River. And so I wanted to check all these communities. But then I started seeing cemeteries, and it looked like there were people in the cemeteries. So I asked my driver if we could stop, and got out and started walking through the cemeteries. There were entire families living in the cemeteries because they had no other place to live. And none of the cemeteries were on our plans to vaccinate kids. So we had to add them into our planning and thinking. So kids are living in all kinds of places that you would never expect. Getting newborns is really, really hard in some places. Many cultures, especially Islamic cultures, but not only them, have a cultural practice of leaving children inside the house for the first 40 days. They think the evil eye is going to get them. And so they don't come out of the house at all. So you have to go in the house and do door-to-door vaccination and get all the newborns. Well, that's really tough if you're in an Islamic culture and you're a male vaccinator. You can't just go into the house and do that. So we have to identify female vaccinators who are trusted by the families, who can go in and find all of the children. It's not as easy as you would think. And getting permission for women to go house to house and have a job like this, that's been a cultural shift. So gradually more and more communities are allowing this. So that's one of the big and positive changes from the polio program. Operational challenges. It was really, really hard to get vaccine up the side of this hill in the Democratic Republic of the Congo. The entire village had to come bail this car out. But people did, and they eventually got the vaccine to where it was going. Security challenges. Our vaccinators and supervisors are working in war-torn areas. This vehicle hit an improvised explosive device in Kandahar, and we lost the driver and our supervisor and one of our epidemiologists. You can see it's a UN vehicle. So you're not safe just because you're a humanitarian worker. And in fact, violence against humanitarian workers is increasing. And violence against polio workers is still very active in Afghanistan and Pakistan. We have planning challenges. The little detailed plans that we do, even when you want to just organize a meeting or this gala, all these things that are coming up, a lot of that detailed planning, logistics, mapping out how much of this and that do we need, that's not really part of their systemic mindset. So it's been very challenging to get every country at the local level to lay out how many households, how many vaccinators, how much vaccine do you need? How are we going to move people from here to there? How many supervisors do you need? How many pieces of paper, chalks, finger markers, all this stuff. That's been a real challenge in getting it accurate. But it's improving. There's feedback after every round to make sure it gets better. Supervision, much the same way, not a skill that you see typically in developing countries. So we're trying to build capacity that will be there after polio is eradicated. Somebody has to be in charge and accountable and go back and double check the quality and effectiveness of what's being done. Kids on the move. Who would have thought there'd be so many kids moving around the world at any given time? I mean, when I first started, I would go to these meetings and they say, well, we go to every community and get every child. I said, then why do you still have polio? No, we don't understand it. We don't know. I said, well, has anybody been to the train station or the border or the ferries or places where that might be off the grid a little bit? And they're like, well, there's no kids there. Those are all adult workers. I'm like, do you know that? Or are you assuming that? Hey, let's go check. So I bring people up to the border with India and Nepal. And we find 100 children under age 5 an hour crossing the border. And I said, we need to start setting up cross-border immunizations. I go to the train station in Mumbai. I'm just looking at kids getting on the train, and it's like click, 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 click. I'm like, we need vaccinators on the train. We go to construction sites. I go to all these weird places. I make the teams take me, and they're like, oh, madam, are you sure you want to go to the brick kiln? I'm like, yes, I want to go to the brick kiln. And they go, but the owner doesn't like you. And I'm like, I'll talk to him. It'll be okay. And I make them take me to these places that they're afraid to go. But we're able to broker access to kids, hundreds of kids at a time. And it all adds up. So on a 3-day polio campaign in India, there's 192 million children under age 5 in India. 5 million of those we vaccinate in transit at some point or another. And that's just one country. When you expand that to all the other countries and look at refugees and IDPs and all these other population movements, there are millions of kids on the move on any given day. We also can't forget what we call underserved populations, refugees, IDPs, nomads, these people who fall through the cracks. Somebody has to be reaching them as well. And as I said, cross-border transmission is really important, and making sure we're getting kids as they cross borders, and that communities that live on borders are being reached either by one side or the other. And sometimes defining where the border is particularly difficult. So that's me up in the corner, and I'm there with those gentlemen. This is the Nigeria-Niger border. And I said, where's the border? And they said, we're at the border. I said, how do you know we're at the border? He said, well, the tree. The tree is the border. And I said, oh, come on, that doesn't look like a border to me. How does everybody know? They go, everybody knows that the tree is the border. So I said, well, let me get somebody coming from the other side. And if they say it's the border, then I'll believe you. So we waited 15 minutes or so, and this Fulani herdsman comes down the path, and we stop him, and I'm talking to him. And I said, where are we? He goes, oh, we're at the border. And I said, how do you know? He goes, the tree. Okay, now I'm convinced that this particular area, they know where the border is, that they plan and work on both sides, and it doesn't matter which side you live on, you can get vaccinated on either side. And that's the way it's supposed to work. But you would never think in the middle of nowhere that it would be that organized, but it actually was. So I was pleased, and they were all laughing at me for waiting to verify it. This other border is quite different. It's a very formal border at a very hot spot. So that is the Afghanistan-Tajikistan border, and I came at it from the Tajikistan side. And you can see all the razor wire, and it's a very, very serious crossing there. And they told me that no kids travel on this border. They don't come that way. And I'm like, do you know that? Or are you assuming that? I said, let's go check. And the Tajik government put a doctor on their side of the border to vaccinate. I went back 3 months later, and they had vaccinated 800 children in 3 months, coming from all parts of Asia. So from China and India and Nepal, Central Asian republics, all over, were coming through this particular gate and getting vaccinated. And just because this one doctor was there doing a couple of kids a day. But those were vulnerable kids. They weren't reached in their home country. So it was really good we had a doctor out there. And then you have these gray zones between countries. That's the Duran line between Afghanistan and Pakistan. And people always ask me, who is Mr. Duran? And there was no Mr. Duran. Some arbitrary committee set up this line between the two countries. And communities are right in the middle. And so it's been very difficult because the two countries don't always get along very well, and they're very suspicious of each other, to try to vaccinate communities, either one group covering the whole thing or from one side or the other side, or how do you split it halfway? But now that we're getting into the very end of polio, and these are some of the last places, we have to overcome these problems as well. So in the last year, there's been a lot more effort to reach these communities. We're also tricky sometimes. So this is a map of a small town in northern Nigeria. And it's a place where they would tell us that we know our community. We know every single house, every single child, every place we have to go. And we said, really, then why is there still polio if you've gotten every single kid? And then, no, madam, we go to every single house. So we did something sneaky, and we put a vaccine GPS tracker in the vaccine carrier. And you can see that the team started out kind of at the bottom, and they went on the main road, and they stayed kind of in the middle of town. And then they went up the other main road, and then they stayed kind of in the middle of town at the other place. But they had all of these missed areas. They didn't go to every place in the town, and they didn't go to the little settlements and the hamlets that are just outside of town, which they were supposed to do. So when they confronted with this map, I was like, oh, we're very sorry. We're like, that's okay. Let's just figure out how to do better. So now we see a satellite map the entire north of Nigeria. And all of these little hamlets and tiny places are now on somebody's map. And someone's assigned to go there. And that's how we've managed to get rid of polio in Africa. It's by making sure we really, really understand where every household and every child is. The world also had a major switch from the traditional trivalent vaccine to the bivalent vaccine. And what they did is take out the type 2 component because type 2 has been eradicated. So we don't really need to protect so much against that anymore. So that was done all over the world, major public health thing, synchronized every place. They got almost no press at all. But for public health people, it was pretty cool to totally take out one vaccine and put in a new vaccine. So that was done, and we think that's going to help eventually reduce any risk of even potential risk of a vaccine, what we call a vaccine-derived outbreak. And because we're using an oral vaccine that's live but weakened, it's not fully killed. So even the vaccine itself can revert back to virulence under certain conditions. And so what we're doing now is trying to reduce the chances of that happening by switching the vaccine, by looking for vaccine-derived viruses, by filling the immunity gap, enhancing surveillance as we get into the very end stage of polio eradication. To put it in a little bit of global context, polio is still a reportable disease under the international health regulations and under the new global health security agenda. So even after eradication and certification, it's still a reportable disease. So there will be people looking for polio well into the future as part of a general pandemic, surveillance network. So right now, part of what we do is figure out how do we transition from polio eradication to after polio eradication. What elements of the program need to stay, and what could be moved on to other programs. Tell you a little bit more about security and access, just so you get a sense for how difficult it is to vaccinate in these remaining places. So this is Pakistan, and as you know, there's been over 100 polio workers or their security staff that have been killed in the last 6 years, specifically because they're polio workers. So the government of Pakistan has assigned people to go with the vaccinators, and especially in rural areas like this is Fatah, so that they can vaccinate safely. And that has helped increase our ability to get kids. This is a map of Afghanistan. So the areas that are green are fully accessible. People can go in, you can vaccinate anywhere you want. That's not so much of a problem. The pink areas, they're only partially accessible. Vaccination teams may only be able to get to part of the country or part of the district, part of the county. It depends which bad guys are there. It depends who's preventing them from getting into some of the highest risk districts. The yellow areas, somewhat accessible, but have major security challenges. So there's active fighting going on in most of Afghanistan. It's a full-fledged war going on. There's tanks and rocket attacks. There's daily activities that are happening there. And then category 4 are places that are entirely inaccessible. No one is allowed to go there, either because of fighting or because the particular bad guys that are there are so opposed to immunization, they've put out direct threats against polio workers. So in Afghanistan, we have a combination of the old Afghan Taliban, which was supportive of immunization. You have the Pakistan Taliban that got pushed out of Pakistan and is now taking up residence in different parts of Afghanistan, and they're not real happy with vaccination. They're the ones that are killing people in Pakistan. And you have IS, or as they say, Daesh, that is also beginning a small presence in Afghanistan, and they're opposed to vaccination as well. So negotiating access with all of these different groups at the local level becomes really important, but it's very time consuming. Local leaders change, your interlocutors change. It's a very challenging environment to be doing the kind of work that they're doing. And so my hat's always off to people that are brave enough to go out and do a lot of this. Pakistan, the government did a major military offensive a couple years back and pretty much pushed back the bad guys out of Pakistan into Afghanistan. But it did open up most of the west of the country. So before they did this, there were over 600,000 children that we could not reach because the bad guys were saying, you can't come in here. This data is at the end of 2015. About 16,000 kids remained that we couldn't reach because of accessibility issues. And I was in Islamabad 3 weeks ago, and that number is under 2,000 now. So by this concerted effort of the Pakistan government, between the Ministry of Health, Ministry of Defense, Ministry of Interior, all the other groups, the UN, the Rotarians there are very active, we've managed to gain access in places that just a few years ago people thought would not be possible. But we've managed to eradicate polio from war-torn places before. The first time days of tranquility were negotiated was in El Salvador in 1985, and they set up multiple truces. That's the little square in the middle at the top. But since then, we've had to negotiate our way out of many situations. So in the upper left, the red shirt and the blue pants, that's me. So that's when I was asked to negotiate the ceasefires among the 3 main rebel factions in eastern Congo. And that is up at Jean-Pierre Bemba's headquarters in Badalit in DR Congo. And I was essentially shuttling between him and Wamba de Wamba, this guy at the bottom, where I'm leaning over the desk with him. We're looking at what was then paper slides or transparencies. It was back that far back. And he was more on the Ugandan side of DRC. And then you had the MLC in Goma. And to gain each one of that group's acceptance for immunization I had to do a lot of talking. Excuse me. And But they basically all had the same questions. They wanted to know, was I being truthful? Could I represent the polio program? Could I deliver on whatever was promised? We had to work out a lot of logistics. Who was going to bring the vaccine? What was the plane going to look like? What were the call letters on the plane? What was going to come with it? Communication equipment, refrigeration equipment. All of that had to get worked out and sorted out in order to broker an agreement. And I had to say the exact same thing to every group, because they all had spies. So they all knew what I was saying in every single group. And when I got back to Kinshasa in the West, they all knew what I had said to every group too. So, being straightforward and being an honest broker of information turned out to be really critical. But we did get a handshake on it, and more than 6 million children were vaccinated. And that ceasefire is in effect today. They still do not fight on the days of the polio campaigns in DRC. There's some other bits and pieces. The only other funny story I'll tell you about is you see me sitting with the lady on the couch. I don't know if many of you remember back in 2003, northern Nigeria stopped vaccinating. And there was a huge international effort to try to restart the campaigns. Well, everybody was doing all the formal stuff, the official diplomats and the UN Secretary General and all this stuff. I went up to Kano and said, the emir is really important in this decision. I said, how many wives does he have? Well, he has 4 wives. I said, which wife does he listen to the most? That's his 3rd wife. I said, can I meet with his 3rd wife? And so that's me meeting with the 3rd wife and telling her about the situation and explaining we really needed her husband to start the campaign again. And I suggested she go home and have a little pillow talk and try to encourage him to, find a way to reverse his actions and start vaccinating. So who knows if that was the tipping point in all of this diplomacy, but I thought I'd do my share in a way that nobody else was approaching it. But pretty soon after that, we got the campaigns restarted. And just to show you that we have done eradication efforts in many war-torn countries. So even though we're seeing struggles now in the remains of Pakistan, parts of Afghanistan, it doesn't mean it's over. I mean, we do find ways to make it work. I talked about transit strategies and cross-border strategies. I'll tell you a little bit about surveillance and making sure that in every single district, county, town, there's somebody searching for polio, acute flaccid paralysis, and tracking it down, detecting it, responding it, investigating it. We're really trying very hard not to miss anything and that there's no gaps in that. We have increasingly worked with communities. So communities are being made aware of what to look for in terms of AFP surveillance and acute rapid onset of floppy paralysis, and bringing that child to the attention of the formal system faster. That way we can respond faster. And we've started doing environmental surveillance. So trying to take sewage samples. Some lucky guy in the Ministry of Health every month has to go with a bucket to the sewage just before the sewage treatment plant and grab a bucket of sewage. They take it back to the lab and they analyze it, looking for any kind of viruses. So polio virus, vaccine virus, anything. And if you don't find virus like that blue one, at the very last column, the blue, that means nothing was growing. And I'm like, what do you mean nothing's growing? Show me a stool sample where nothing grows. That's impossible. Poop is not sterile. I said, there's a problem at that site. Go back and investigate. And so these do give you little clues to where there may be problems in the program. So hopefully that'll get fixed pretty soon. This is even way beyond me sometimes, but occasionally I get a virologist in the audience. So this is a dendrogram. This is the family tree of viruses. And it's the genetic sequencing. So it says what type, what subtype, what its closest relative is, how long it's been circulating before it was last detected. For some people, this is just a wealth of data. For me, I try to look at it like a family tree. Oh, Afghanistan. Well, that's not too far from Pakistan. Okay, and then you see where they were living, and you can kind of get an idea. But for some people, this is like the backbone, the meat of the program. Polio has been declared a public health emergency, and many countries require proof of immunization to go or come from there. And if you haven't gathered, how do we get this close right now? International cooperation, and Rotary International has been at the forefront of this from the very start. Human and financial resources, evidence-based approaches, moving beyond epidemiology to include diplomacy, defense, development, understanding social issues, religious, cultural, tribal issues, and that we can't just get 80% or 90%. That's not sufficient. We really have to get every single child. We've had great political support, and Rotary in Your This Close campaign is huge. It's worldwide. It's everywhere I go, I see it. But it takes heads of state. It takes UN agencies. It takes the private sector, including Rotary, but that's Mr. Gates, has also been very, very engaged in the program with the Bill and Melinda Gates Foundation. This is an old slide, so the numbers are not right, but just to show you how many governments participate in polio eradication. It's huge. It's a $1 billion a year program. The U.S. government puts in somewhere around $170 million a year. Rotary's put in well over $1.5 billion. Mr. Gates has put in well over $1.5 billion. But all these other groups are all contributing as well. And they feel that ownership towards the program. We still have a ways to go. For every year the program's delayed, it costs about another $800,000 to $900,000. So there's a plan for trying to raise more money, not necessarily from Rotarians, but to hit up some countries that haven't been paying their way. And then, I always want this to work, and it's not working. Let's see. There is a slideshow here that for some reason, here we go. Let's see if I can get it to work. Okay, so this is bringing vaccines all over the place. Just to give you a sense of what these teams do to get out. It's a solar panel.
Is that to keep it cold?
Yep, they have to keep the vaccine cold.
Does anyone have questions while we're watching?
I'm 2 slides away from finishing. Okay. So just to remind you that the global polio eradication effort is the largest effort outside of armed conflict anywhere in the world. There's 20 million volunteers, health workers, lab techs, vaccinators, mobilizers dedicated to the common cause of preventing childhood paralysis. And we estimate that we prevented 13 million cases of polio so far. That's my contact info, and thank you. It's been a pleasure.
I'm so impressed and so happy that we were able to have you here today.
Oh, my pleasure.
Thank you. And let me do our little... Have a book. It's not for you. We
That's
don't
okay.
give you anything, which is
Understandable.
not right.
Well, you've given me a lot, actually, but
we do present a book to a local child care
Fantastic.
center in your honor. This is The Tortoise and the Hare,
perfect.
and it is by Jerry Pinkney. And the inside label says, on this 27th day of July, 2016, in honor of our speaker, Ellen Ogden, the Rotary Club of Warren County presents this book to the Little Sheep Preschool.
Perfect. What a
So-
perfect choice. That's great.
Thank you again.
Thank you.